welcome to another exciting episode of MedSynapse podcast series. I'm your host, Hetvi Shah, and today we are diving into the cutting edge world of surgical oncology. Over the past decade, surgical techniques and technology has revolutionized cancer treatment, improving precision, recovery, and outcomes. And to guide us through these advancements, we have an expert in the field, Dr. Jitender Rohila. With over a decade of experience, Dr. Rohila specializes in GI oncology, robotic and laparoscopic surgeries, and complex procedures like HIPAC for peritoneal cancers. He has trained at some of the most prestigious institutions, including AIMS, Tata Memorial Center, and Saifi Hospital. So, Doctor, it is an absolute pleasure to have you here and welcome to the show.
Thank you, Hetvi. Thank you for having me here, and it's a privilege to be on your podcast.
Thank you, Doctor. Likewise. So, Doctor, before we start talking about surgical oncology, would you just provide an overview of your professional journey to us?
So I'm basically a surgical oncologist. Surgical oncologist means cancer surgeon, the doctor who specializes in surgical treatment of cancers. So I did my graduation from PGIMS Rohtak. It's in Haryana. Then I moved to AIMS New Delhi for my post graduation, which is Master in Surgery. And then for super specialization, I was in Tata Memorial Hospital, Mumbai, which is the best center for cancer treating. My MCH, I specialize specifically in GI cancers, which is gastrointestinal or digestive system cancers, where I was trained to the latest techniques for doing these type of cancers, namely robotic surgery, HIPEC surgery, and all other advanced treatment. So I got that, and now currently I'm with Fortis Group of Hospitals. It's a dedicated Fortis Cancer Institute in Mohali, Punjab.
Yeah, that's an good and inspiring story, Doctor. Now, to start with, surgical oncology has evolved significantly over the past decade. So, what are some of the most impactful advances that have transformed patient outcome?
So surgical oncology initially started as an extension of general surgery, right? The general surgeons who were trained in doing cancer surgeries were doing surgical oncologists, but now it has specialized more. There is a MCH program, which is a super specialty program, which we get trained into surgical oncology programs. And then now, after advancement from the last 1 decade, we are moving toward organ specific surgical oncology, which means that a particular surgeon who's trained in performing cancer surgery will deal with a particular type of organ system, like a breast cancer surgeon, head and neck cancer surgeon, gastrointestinal cancer surgeon, gynae cancer surgeon, and musculoskeletal or bone cancer surgeon. So we have specialized into that era. First is this one. Second, from my field, if we talk about GI cancers, we have evolved a lot. Initially, you must have heard that all surgeries all being performed with open technique, but now we are moving toward minimally invasive techniques, which is doing the same surgery with smaller holes so that patient can have better recovery in the post-operative period. In the minimally invasive surgery, the latest technique is doing robotic surgery. We'll discuss about that in the podcast. And we have progressed in stage 4 cancer treatment also. There has been advancement in medical oncology side, the chemotherapies, immunotherapies, they have progressed. From the surgery side also, in stage 4 cancer, we have been able to offer them cytoreductive surgery, HIPEC surgery, PIPEC surgery. And these are some of the advances in my field. And similarly, there are advances in other fields also of surgical oncology. So it has evolved a lot in the past decade or so.
Correct. Yeah, I think that's very fascinating, and I think integration of minimally invasive techniques has actually reshaped also oncology care. Now, Doctor, speaking of innovations, only like HIPAC that you mentioned, it has gained a lot of attention for treating peritoneal malignancies. So, can you walk us through the latest evidence supporting its role in GI cancers?
So, first of all, I will tell you what is HIPEC surgery. It is basically a method of administering chemotherapy inside the abdomen. So, it is called hyperthermic intraperitoneal chemotherapy. So it is a device, surgical treatment devised for stage 4 cancers, which are only limited to peritoneum. What is peritoneum? Peritoneum is an inner lining which will line your internal organs. So in your abdomen there is a layer called peritoneum which will protect all these organs. Suppose the cancer goes there, it is called a stage 4 cancer. So, but if it's very limited disease, then we can do a surgery in them, which is called cytoreductive surgery. Cytoreductive surgery means the surgeon goes inside, whatever disease is seen or visible to him, he will remove all that. That is called cytoreductive surgery. After ensuring cytoreductive surgery, he will put the chemotherapy inside, keep it for 90 minutes or so, and then close up the patient. So it is administration of chemotherapy at the time of surgery after doing a complete cytoreductive surgery. What cancers it can be used in if we talk about GI or digestive system cancers, there is colon cancer, stomach cancer, and if we talk about gynae cancer, ovarian cancer, the ovary cancer is there. So in ovary cancer it can be used, and there are some cancer which will originate from the peritoneum. Those are very rare, but if we can diagnose them, which is called as pseudomyxoma peritoneum. It was initially called as jelly belly. Like there is a lot of jelly-like material which gets filled in the abdomen, and patients become very symptomatic. They have huge abdominal distensions. Historical treatment was repeated evacuation of mucin, but now we can give them cytoreductive surgery and HIPEC. Pseudomyxoma peritoneum is the only cancer we will talk about survival in terms of 10 years, 15 years. No other cancer will talk about that. We only talk about cancer survival in terms of 5 years. What is the 5-year survival? So pseudomyxoma, if it is done by a well-trained surgeon, is good cytoreduction and HIPEC will give them a very, very good survival. Similarly, peritoneal mesothelioma, there are rare diagnoses. They are usually treated as abdominal tuberculosis, but when once someone does a laparoscopy or a biopsy, then we find them in mesothelioma. If it's a low-grade mesothelioma, then also it's a gold standard. In ovarian cancer, now we have the level 1 evidence to suggest that after giving chemotherapy in stage 3 or stage 4 ovarian cancer, if we do CRS and HIPEC, these patients tend to have a better survival outcomes. So these are the disease set of where we can offer them cytoreductive surgery and HIPEC, and a lot of research is ongoing right now. In future we will find very good evidence for colorectal, stomach cancer also, and I am very hopeful that we will be able to give meaningful survival to this stage 4 peritoneal limited cancers also.
Yeah, I think that is a game changer also, doctor, and thank you for sharing that incredible insight. Now, alongside HIPEC, as you also mentioned earlier, like robotic surgery has been making waves in GI cancer treatment. So, how has robotic surgery improved precision patient recovery and long-term oncological outcomes in GI cancer cases?
So as I have mentioned earlier in my introduction also, so robotic surgery is mainly an extension of a minimally invasive surgery. So what is minimally invasive surgery? Minimally invasive surgery means you give smaller holes on the abdomen and then do surgery. So if you do surgery with smaller holes, then the patient will have less pain. He'll be able to walk early. The recovery will be smooth. He will be discharged early, right? So if we are doing minimal invasive surgery can be done by two ways, either laparoscopic surgery or robotic surgery. Robotic surgery is a latest system to do surgery. It is not that the robot is doing the surgery. It is a surgeon only who is performing the surgery. But the robot system is helping the surgeons do the surgery in a better and a precise way. What are the advantages of robotic over laparoscopy? It has a 3D camera, right? 3D camera with depth perception. It feels like you're sitting inside and performing the surgery, right? You are very close to the organ. You are removing only the organ which is affected by cancer, and you are preserving all the structures which are important for a healthy life. Right? If I talk about a rectal cancer, rectum cancer is it is very closely associated with important nerves, autonomic nerves, which will control the urinary and the sexual function of the patient. So if we damage that, then this patient tend to have urinary and sexual dysfunction in the post-operative period. But with robotic technique, we are able to see clearly, we are able to preserve the nerves, and these patients tend to have very good functional outcome post-operatively. And in pelvic surgery, it is a game changer, right? In pelvis surgery, the space is very less. Especially in male pelvis, the space is very, very less. When you have to do cancer surgery, we sometimes struggles when we are doing a open surgery or a laparoscopic surgery. The robotic surgery, the camera is long, the instruments are long, and the movement of the instruments is also like this, right? they can wrist. So
Mm.
it is basically doing an open surgery by minimal invasive approach. And in the pelvis, you can reach very, very down into the deeper pelvises, do your surgery and come back by just removing the tumor and preserving all the important structures. So robotic surgery is definitely a game changer. It is only removing the cancer. It is preserving all the important structures. Like important is, if I give an example of rectal cancer, majority of our patients, when they are young, they will avoid doing surgery when we offer them a permanent stoma bag. It's a colostomy bag which collects the feces outside. Sometimes we have to give them if the disease is very, very low. But if we are doing robotic surgery, then we can offer them sphincter preserving approach, in which we are not giving them a permanent stoma and preserving their function of the rectum. So that is just an example of it. It is useful in many diseases like esophagus, food pipe cancer, where we have to do the surgery in the thorax also, abdomen also, neck also. So when we do by robotic surgery, these patients tend to have very less complications in the post-operative period. If we give them a big incision on the chest, then they have pulmonary complication, they have pneumonias and all. So, but if we do that with minimal invasive or a robotic approach, these patients tend to have a better post-operative outcomes, and they can start their adjuvant treatment also. Suppose some patients require, say, adjuvant chemotherapy, adjuvant radiotherapy, so they can finish their surgery, get recovery early, and start their chemotherapies and radiotherapies if it's required.
Yeah, actually, rightly mentioned that it actually makes the post surgery also easier for patients and for doctors also. It is really helpful. It's not going to replace doctors in any way.
Yes.
So, doctor, but of course, there's surgical oncology is not just about the procedure itself, because multidisciplinary collaboration plays a huge role too. So, what are the best practices for integrating surgical, medical, and radiation oncology perspectives into treatment planning?
So, as I was trained in Tata Memorial Hospital, Mumbai, it is the best cancer center in the country and in the world also. So, there we were told and taught that we have to have a multidisciplinary approach, right?
Yeah.
Only the surgeon or a radiation oncologist or a medical oncologist alone cannot treat the cancer. Okay, they have to come together, form a team, and have a comprehensive setup. Then only we can treat the patients better. So we at Fortis Cancer Hospital Mohali are also following that approach. We have a tumor board approach. Every patient who comes to us for the first time, we'll assess them, we'll diagnose them, we'll form a stage for them, and then the plan is made in that meeting, right? We have inputs from the radiation oncologist, we'll have input from the medical oncologist, we'll have input from the pathologist, radiologist, nuclear medicine physician. Everyone will give their inputs, and then we'll look at the evidence also. So the guidelines is saying this, then we'll discuss on that, and then we'll formulate a plan for the patient. So it is important that every person is giving their inputs, then only we can give the best survival to the patient. So especially in gastrointestinal cancers, it is usually, suppose a rectal cancer is there, we have to give radiation first, then do surgery. Sometimes we give radiation first, sometimes we do surgery first, then give chemotherapy. So that decision making is very important. So everyone will give their inputs, we'll discuss it together, and then we formulate a plan for the best outcome of the patient. Fortis Cancer Institute has a comprehensive cancer setup. We have all facilities available. Like we have talked about robotic surgery, we have the latest medical oncologist immunotherapies also. We have radiation technologies, latest radiation machine also available. We have the PET scan. We have, everything is under one roof. So patient does not have to wander here and there. He can get his treatment at a comprehensive cancer center. That is very important for the patient. The message should go across. Whenever the patient is diagnosed with a cancer, he should only get the treatment at a center which is comprehensive. All the facilities are available under one roof. Then only the outcomes will be better for the patient.
Yeah, that is actually, I think holistic approach is key from like pre-treatment for to treatment to post-surgery as well. I think that is really important for
It
a
is like
patient.
hand holding for the patient, right?
Correct.
We have to hold
Yes.
the hand of the patient. Whenever someone is diagnosed with cancer, it is not only the patient who is affected, the whole family is affected. Their whole psyche gets affected. They feel depressed. They need some help. So we, as clinician, can only help them not only get their treatment, we can
Make it easier.
hold them and take it through their journey with successful outcome.
Correct, correct. Rightly mentioned, doctor. Doctor, for finally, for young surgeons looking to specialize in GI oncology, I'm sure they'd love to hear your advice. So, what advice would you give to young surgeons and oncologists looking to specialize in GI oncology?
So, being a GI cancer surgeon, I would say them it's a fantastic branch, and we face a lot of challenges. There is a challenge in decision making, surgical treatment. The surgeries are more extensive, they are more challenging, and post-operative outcome is also important as compared to other specialties. The complication rates are also higher. So my advice to all the junior surgeons who are aspiring to be GI cancer surgeon is get trained very well. Okay, before you jump onto going into individual practice or a job, get yourself trained in all the latest technologies. Plus, work at a center which is giving you a lot of experience in terms of a lot of patients you are observing, a lot of patients you are getting to hands on. Uh, get trained under a mentor. Like I was fortunate enough to be trained under Dr. Avnish Saklani, who is the best colorectal cancer surgeon in the country, in the world, we can say. Under Dr. Sanket Mehta, he's the best high-pec surgeon in the country. So I've invested a lot of time there before jumping on, because when I was joining here as an individual consultant, there is a lot of responsibility on my shoulders that I have to give them the same treatment options as I was getting, the patients were getting in Mumbai or a best cancer center in the country. So I am proud to say that we have been able to offer that here. So it is only possible because I was trained by such mentors, and I still follow them. I keep on taking advice from them, and that is the mantra to success. So learning never stops. Keep learning. Get yourself a good mentor, and then only progress towards
Yeah.
this field. Thank you.
Right. I think that's an invaluable advice for aspiring oncologist doctor. And as we wrap up today's session, thank you so much for sharing your expertise and insights on this topic. And it has actually given a deep dive into the ever evolving world of surgical oncology. So thank you so much for sharing that.
Thank you, Hathmi, and thank you for having me here. And I hope this podcast will serve better for information, spreading awareness towards the latest technologies available for surgical oncology. Thank you.
Yeah, definitely. And to our listeners, thank you for tuning into this episode. And remember, if you're a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. Until we meet again, stay informed and stay inspired.